These are the first Indian guidelines approved by the Indian Society of Hypertension. So these guidelines are framed on the basis of the Indian data. Whatever Indian data we have, still Indian data is not very nice, but still whatever we have, and we have taken the leaves out of the other guidelines, which are very recent guidelines like the European Society Hypertension Guidelines, International Society of Hypertension Guidelines. What we have done, we have taken the things where the Indian data is lacking. We have accepted the norms all over the world which are being followed. As Dr. Anush told, that we have also taken some initiatives from the Chinese Society of Hypertension Guidelines. So these guidelines are the consensus guidelines in 2023, and this is the edition 1. We will follow more edition in the coming time when the Indian data will pour in, and we are trying to create Indian data, and hope that Indian data will also help framing the Asian guidelines, because the Asian guideline consensus can also be made out of the Indian, Chinese, Taiwan, in the Korean, and other guidelines can have the consensus, and we can have the Japanese, we can have the Asian guidelines as well. So these are the persons involved, basically myself, our president, Dr. Rajiv Gupta, and the Dr. S.N. Narsingh and Kamalakar Tripathi, sir. We were 2 senior physicians and cardiologists, endocrinologists were advisors to this. And then we had lot number of speakers, experts, and these experts were constantly in touch. And for 9 months, we had mind-boggling sessions. And then we decided to carry on and to print these guidelines. And but in these guidelines, we have found that the India has around 32.6% of women and 38.7% of men are more than age of 20 years are having hypertension. So here we have taken 20 years because adolescent hypertension is different, and we have found in our studies that adolescent hypertension in India is variable, but it is around 4%. So that is why we made this guideline. And the guidelines were having 5 clinical experts, 2 advisors, and they were very senior fellows, I have already mentioned. And these clinical experts were having the review committees, and then the consensus process was made, and the Delphi consensus conducted to finalize the recommendations. And according to that, we defined hypertension, which is not very different. It is around the same definition which were presented by International Society of Hypertension. Regarding the data we had, and we found that in India, it is wise to have the optimal blood pressure less than 130/85, which is different from the Chinese one. Chinese guidelines had mentioned less than 120 and less than 80. In India, we have kept it less than 130 and less than 85. So why this is? Because of the May measurement data and more data we had. Out of that, we found that this will be more accurate for the Indian setup. Then high normal blood pressure, it is almost same, and the grade 1 and grade 2 hypertension, we have limited ourselves to grade 1 and grade 2 just to decrease the confusion among the physician, so that grade 3, grade 4 and other classifications have not been included, because that will unnecessarily confuse our physicians. And we are in the opinion, according to our data, that the control rate in India is poor, and that is good in China. So we will take the leaf out of China to improve our control rate and to have less confusion among the mind of our physicians. It is better to have grade 1 and grade 2 hypertension. Then we had that screening. In India, we have, in our setup, we have data which suggests that all Indians need screening who are more than 18 years age. They need screening, and this is called as, whenever any person comes to your contact, screen for blood pressure, screen for hypertension. So the patient has a risk factor, no risk factor, does not have any impact. You have to screen for blood pressure, and once the screen for hypertension has been done, and if it is 130, 180, 130 to 139, and 85 to 89 millimeter of mercury, then high normal blood pressure, and then the office blood pressure measurement is not enough. It requires out of office measurement, and then definitely we have to repeat it after a certain time that we have decided 1 to 2 weeks. Similarly, we have decided the level of blood pressure and then the grade 1, grade 2, grade 2 hypertension. Then we decide grade 2 with the multiple organ damage or the hypertension mediated organ damage or without organ damage. On the basis of that, the screening and repeated measurements are ordered. And we have been more emphasizing on the mask hypertension. In recent data being published, we have found the one data which has been grand study. We have been able to found that Indians have more mask hypertension. So this was surprising data for us. So mask hypertension, white coat hypertension, pseudo or false resistant hypertension, and the mask uncontrolled hypertension. These were the categories which were emphasizing, and we emphasize in our guidelines that they should be taken in account. And we have more focus on the measurement techniques, and we have advisory that how the blood pressure should be measured and what are the best methods to measure blood pressure. And the measurement is an issue in my country, and still the most of the Indian physicians are not convinced that the this monitor using the automated method is better. So we have more emphasis on that, and we are trying to increase awareness regarding the automated measurement of blood pressure and having quality devices for that. And we had the regarding diagnosis, standing blood pressure, and home BP monitoring, ambulatory BP monitoring. In our guidelines, we have focused all that. Who needs the standing BP? Who needs the home monitoring? Who needs the ambulatory one? In our guidelines, on the basis of the some Indian data, we have emphasized that these are the people who require that. Moreover, we have more emphasis on the training the staff, how we can train the staff who can measure blood pressure, because physicians themselves are not measuring blood pressure. So our emphasis will be more on that. And our guidelines have included which arm should be selected and why, and the device preferences we have also kept in mind. And at present, Indian guidelines say that avoid mercury, aneroid, and cuffless. You have to use only upper arm cuff automated devices. So our recommendation is very clear. Use the upper arm cuff automated devices. Then in physical examination, we have been able to emphasize that the anthropometry is important. You record anthropometric data so that in the coming time we can have Indian anthropometric data. And the cardiovascular examination, respiratory examination, abdominal examination, neurological examination, and fundoscopy. They are very, very important, and we have included in our guidelines that they should be done. We are emphasizing on this that they should be done to find out the hypertension mediated organ damage. And then on investigation, we have emphasized for urine analysis for proteinuria and how the proteinuria can change the things, and we have emphasized that. And not only that, targeted screening for high-risk groups, more frequent screening for high-risk group, especially elderly more than 60 years, which is similar to China. And the obese people, the smokers or tobacco users. In India, tobacco use is different. It is not only smoking. We have more than 11 type of tobacco users. So we are emphasizing more on tobacco rather than only on smoking. And those with diabetes and cardiovascular disease, we have more targeted screening for them. And then we have emphasized our physicians to record the history of and physical examination for risk factor for tobacco, obesity, diet, and exercising patterns, family history of premature CVD, angina, heart failure, and stroke. Similarly, we have kept the diagnostic approaches in form of ECG for everyone, if possible. And most of the time in India, ECG is available almost everyone. But echocardiography, the limiting factor, every Indian city do not have this facility. Indian city has, but the village areas may not have that facility. So we have not made it mandatory, but we have written that if possible, it should be done. And similarly, carotid ultrasound, whenever available, and peripheral arterial disease must be kept in mind, and reduced kidney function and glomerular endothelial dysfunction. For that, microalbuminuria almost available everywhere, and the arterial stiffness. For that, the carotid femoral pulse velocity, which is brain imaging whenever possible. I agree that this brain imaging, whenever it is available, we have kept it in our guidelines. Then in diagnostic workup, we have emphasized on the cardiovascular risk factors, the then assessment of these risks and elevated serum uric acid had been included, because in Indian population, we have found in our data that uric acid level is very high in most of the Indians, and the females have more high uric acid. So we have kept this in our guidelines. The hypertension and coronary artery disease, hypertension and previous stroke, hypertension and heart failure, and hypertension and chronic kidney disease. We have described the goal for all of them, and this has been done according to some Indian data, whatever we have. And the definition and role of the hypertension mediated organ damage in hypertension management have been highly advocated to include all this, and we have advocated the increased workload on the heart, hypertrophy, and the brain, kidney, eyes, blood vessels. They all have been included so that our physician can think on this direction, and we can reduce the burden of hypertension mediated organ damage. And not only that, we have also included in our recommendations regarding the hypertension mediated organ damage, routine assessment of EGFR by the CKD-EPI formula, 12-lead ECG, urine albumin, and UACR, urine albumin creatinine ratio. Consider cystatin C if available for early nephropathy detection. This cystatin C may not be available at every center, so we have kept it optional, and routine clinical examination, including peripheral vascular, carotid artery, and fundus examination. So this all we have included. Then the screening for BP influencing substances. We have, this is new thing we have included. BP influencing substances are very common in our society, and we have included them. And only then we have talked more about lifestyle modification, because today's India is having a lot of lifestyle related problems, and we have included that. Then the prioritizing, achieving, and maintaining target blood pressure levels, enhancing hypertension management, and serial hypertension mediated organ damage monitoring. This we have included. Then we have kept in our guidelines regarding the sodium intake, the guidelines about that, and say that physicians should include it and advocate and talk about your patient regarding sodium intake. Alcohol and other substances like caffeine, nicotine, they are increasing day by day in our society. Tobacco, NSAIDs, the acetaminophen, corticosteroids, the calcineurin inhibitors, and the menopausal hormone therapy, again, very, very important issue, anti-cancer therapy, and other drugs which can interfere with the hypertension. And we have also our recommendation regarding the lifestyle modification, impact of medication on blood pressure, the different medication the patient may be receiving, individual variability in response, older individuals, younger individuals, rural individuals, urban individuals, they all have different responses. We have also kept one advice regarding that, and the lifestyle modification treatment to target, we have emphasized for that. And then for the treatment purpose, we have included the grade 1 hypertension. We have said that if monotherapy is sufficient, you can continue with monotherapy. And like other guidelines, we have kept the RAS inhibitors, CCB, or the thiazide diuretics in most of the cases in India. And like other guidelines, Indians also do not prefer, and we have not used beta blockers as first-line therapy. The lifestyle interventions like dual therapy, this is required for the grade 1 hypertension in some cases, and most of the cases are grade 2 hypertension. So even when the dual therapy required, then CCB, ARB, and ACE, ARB are ACE, and CCB are the best combination we have recommended. Then the combination therapy, we have included all the 4 drugs and the combination as per patient's risk factors. We have advised that to find out risk factor, and on the basis of risk factor, you can combine. We have still not included ARNI in that, but taking a leaf out of the Chinese guidelines, myself, Professor Anuj and Professor Swati will definitely carry out few research programs, whatever possible in our Indian scenario, and then we can also go for that, because theoretically I believe that RV can be a very good candidate for treating hypertension. Then we have more about the cardiovascular disorders. We have advice for that, and these are the areas where our guidelines are more talking about. The valvular heart disease in India is not that common nowadays, but still we have a lot of patients. And cognitive impairment, again, a big problem. And this all assessment we have advised to our physicians that they should take time to time and talk about comorbidities and their management, like psoriatic arthritis, very important disease to talk about. Glaucoma in hypertension, hypertension oncology. Again, we have included in our guidelines, very important thing, because these drugs which are used for treatment of cancers, they produce hypertension and diabetes both. And follow-up we have talked about in length. Then we have recommendation regarding the first line therapy, and we have kept RAS blockers as first line therapy as other guidelines, because in our Indian setup, we are having increased RAS activity. So that is why we have kept the RAS blockers as the #1 drug. Then additional medications, whatever requires for proteinuria control, then CCBs and diuretics have been kept, and the blood pressure targets we have talked about. The monitoring we have talked about, and caution, what caution one should take, we have included in our guidelines. And the ACE inhibitor, thiazide, or thiazide-like diuretics and loop diuretics like furosemide are alternate options when the volume overload is there. So we have kept the hypertension treatment in CAD differently, and here we have advised beta blockers like other guidelines. And we have talked in length about the therapeutic goals in CAD and medication considerations on these special situations, like the heart failure prevention. We have talked in length, and here definitely the ARNI has a role, and we must keep this mind. At present in India, the SGLT2 inhibitors are taking an upper hand, and they are being more used by the cardiologists. And according to the data available, we have also kept SGLT2 inhibitors as a drug whenever in diabetic individuals and even non-diabetic individuals, we have kept them, because in India they are being used a lot. And the heart failures, keeping in mind the according to the international guidelines and Indian guidelines as well, we have kept the drugs in relation to heart failure. And we have talked about more in stroke, because I feel that, and our committee feels that stroke is the highest risk a hypertensive individual has. But the neurologists are not aware of that hypertension, and they hardly treat hypertension. And 70% of hypertension is leading to stroke, and that hemorrhagic stroke management, how it is different from ischemic stroke management. We have very emphasized view on that, that the slow and moderate reduction of blood pressure is required, not aggressive. In ischemic stroke management, even the blood pressure should be maintained above goal, that is 180, more than 180, or 180 and 105 in first 24 hours to reduce the chances of increasing infarction. So we have talked in detail about ischemic stroke and thrombolysis, and we have taken account and advised our physicians regarding the eligibility of IV alteplase, lower SBP to less than 185, and spontaneous intracerebral hemorrhage and secondary prevention of spontaneous ICH. We have talked in detail about that, and we have kept in our guidelines. And the CKD, in CKD especially, we have talked about in our guidelines, and the target BP in specific CKD groups and albuminuria and medication choice in that particular situation. Hyperkalemia, we have emphasized and use potassium binding agents to maintain serum potassium at the level less than 0.5 and enable continued RAS blockers or MRA treatment. We have advised our physicians do not stop them haphazardly, just monitor it. And we have talked about renal sympathetic denervation. I'm happy that Chinese guidelines do have this mention, and we have also the regarding this particular thing in our guidelines. The combination therapy considerations have also been included, and the rigorous BP control is pivotal for CKD. We have emphasized that, and tailored approach we are advocated. Then we have talked about the type 2 diabetes. It is difficult to treat hypertension. And here we have emphasized the goal, which is always less than 130/80, what challenges one can face. And we have talked about role of SGLT2 inhibitors. And we have talked more about nighttime BP monitoring. And for that, we have advised ABPM in those suitable candidates. And even the home monitoring during nighttime is enough for most of the patients. Then antihypertensive treatment in diabetes, we have discussed in detail, and threshold we have discussed. And then we have given the conclusion remark in every setup that what should be done for type 2 diabetes patients. And then we have talked more about resistant hypertension, secondary hypertension, endocrinal hypertension, renal hypertension, renovascular, and the vascular hypertension, neurogenic hypertension, and various drugs and toxins which can produce hypertension. And we have kept different volumes on the hypertension in elderly, hypertension, acute stroke, hypertension, diabetes, HIV, COVID-19. This all we have kept in our guidelines. They are very detailed guidelines. And we have talked more about gender disparities and women in hypertension, hypertension in pregnancy. So all this has been included in our Indian guidelines. Whenever we had Indian data, we have utilized that. And when the Indian data were lacking, and safe medication during pregnancy, all these things, what to do for aspirin for preeclampsia and managing pregnancy hypertension, all these things have been talked in detail. Endocrine hypertension has also been included, and primary hypertension, often referred to as essential or idiopathic. We have talked more about that, and the secondary hypertension, especially endocrine one. And then screening regarding the secondary hypertension and the further investigation, special referrals, all which have included. And we have also included obesity and hypertension. And here we have some Indian data. According to that, we have advised that what anti-obesity drugs can be used and how they can affect hypertension. And then we have talked more about telemedicine and EHR. We have emphasized we are encouraging the Indian physicians to use more and more EHR so that they can utilize the services of telemedicine as well, so that the population of India can be managed. And similarly, we had more talk about the recommend regular users of electronic health records, which is lacking in my country. We are emphasizing for that. Neonatal hypertension we have covered, and the children or adolescent hypertension I talked about. We are running few programs for that, and we have screened few cities for adolescent hypertension. So we have kept this in our guidelines. And we have also included in our guidelines that what should be our approach and how in a single glance, one can learn about hypertension. So that was regarding the Indian guidelines. Still, they are primitive one. This is the first attempt, and with the coming time, when the Indian data will pour in and some Asian data or friend countries like China, Korea, Japan, we will improve our guidelines further. These guidelines have been published in Hypertension Journal of Indian Society of Hypertension. They have been submitted to the Journal of Human Hypertension, and we hope that we will publish them very shortly. And we are reaching out to every physician of India to have these guidelines and the glimpse of these guidelines. With this, I would like to end here. Thank you. Thank you very much.